Step one in a situation like this is get to the bedside and confirm what is going on. This is a situation where we have two competing serious problems or two competing serious risks. A lot of time when we're using a drug like anticoagulation, we are treating risk and we are balancing that against other risks. In the case of an acute life-threatening pulmonary embolism, anticoagulation is the best treatment. There are very few circumstances in which I will recommend against anticoagulation. Unfortunately, this is one of them. This is a patient who is extremely high risk for bleeding into their brain, which can rapidly be fatal. At the bedside, patient was stable from a respiratory perspective, but on very high respiratory support. And if he got worse, was going to need to be intubated. This is a patient with widely metastatic cancer, and so undergoing intubation is a serious step to undertake. Very real possibility that that patient would never be able to come off the respirator, especially if we elected not to treat the reason for the respiratory failure, which is a massive PE. Of course, neurosurgery was involved. This varies from institution to institution and from surgeon to surgeon, but where I was practicing at the time, their general reflex for patients that are post-craniotomy is no anticoagulation, no therapeutic anticoagulation until 14 days post-op. At that time, brain imaging showed that the metastatic lesions had no new bleeding compared to prior imaging. We determined we're balancing a problem, acute massive pulmonary embolism, against a risk, a very, very high risk of lethal bleeding. Starting blunt thinner is no doubt going to increase that risk, but that's the most effective treatment for the acute pulmonary embolism at that time. Patient already had an IVC filter in place, and thrombectomy would also be considered, but it should be understood that thrombectomy is only effective if you can also anticoagulate. So with me, with neurosurgery, we had a long discussion with the patient and his family about the big picture, metastatic melanoma, the competing risks and competing problems, and together we made an informed decision with the family of what treatment to take. Elected to start anticoagulation with an unfractionated heparin drip and very close monitoring, and the patient's respiratory status did improve. Unfortunately, he passed away from bleeding brain mets a few days later. Please note that to respect the privacy of all of my patients, I've changed some of the details in this specific case, but the basic clinical principles still apply. And unfortunately, I've been in many situations where we're balancing the need to treat a life-threatening pulmonary embolism against a very high risk of bleeding. Tough situation to be in. This is a case of there's no right answer here, but what I recommend is get to the bedside, assess what is going on and what is the top priority to treat, and make sure you've got all the experts involved and that you're educating the patient and their family as well as you can in a difficult circumstance like this. Hope that helps. Follow for more information about blood and cancer.